Okay, whenever we are managing any cases of ocular burns, the primary goal of management is, in these cases, is glue preservation and ocular surface maintenance. And to achieve these goals, we must have some surgical principles, and that includes that 5 principles, and that includes that regardless of the underlying chemical involved, common principles of management include removing the offending agent, controlling inflammation, promoting ocular surface healing, controlling intraocular pressure, and prevention of infection. So, immediate copious irrigation remains the single most important therapy for treating chemical injuries. Ideally, the eye should be irrigated with a sterile balanced buffered solution such as normal saline or balanced solution, BSS plus or Ringer's lactate solution. Why balanced buffered solution? Because this can cause less exothermic reactivity inside the eye. In cases, if there is no proper suitable fluid, you can use this plain tap water also. The diphoterin is the main irrigation solution of choice in these cases, but it's very difficult to get it. So the irrigation solution must contact the ocular surface, because in these cases these patients are having a lot of blepharospasm, they don't want to open the eyes. So you have to, at least once only you have to put the anesthetic, but we cannot put anesthetic quite frequently, because topical anesthesia can increase the penetration of the chemicals inside the eye. This can be, that means just putting 1 drop of topical anesthesia will suffice, and then put an universal speculum, or you can use this Morgan lens. Irrigation should be continued until the pH of the ocular surface is neutralized, and we should check it every 5 to 10 minutes. Usually requires 1 to 2 liters of fluid and for at least 30 minutes. And after this, we have to evert the lid margins and see that whether there is any foreign particles present or not. And sometimes we have to go for double eversion of the lid margins by using Desmarais retractor. Sometimes tuna particles can be found in the fornix, and then you have to remove it by fine forceps. So once the irrigation is completed and pH is neutralized, a comprehensive examination can be performed. So at this stage only we can go for proper assessment of the injury. So first we have to go for irrigation, and then after that we can go for proper assessment of the injury, and then we can classify what type of injury to prognosticate the case. And the severity of a burn depends on surface area of contact, depth of penetration and concentration, time of interference since contact, and degree of limbal stem cell injury. And common areas include anterior segment and internal segment of the eye, cornea, conjunctiva, and the lens can be involved. And the second principle is that control of inflammation. So inflammatory mediators released from the ocular surface at the time of injury causes tissue necrosis, and this inflammatory response not only inhibits epithelialization but also increases the risk of corneal ulceration and perforation. So controlling inflammation with topical steroids can help break this inflammatory cycle, and intensive topical corticosteroids has for decades been one of the mainstays of treatments, and it remains as such. A potent corticosteroid eye drops such as dexamethasone 0.1% or pedacetate 1% should be started from the day one, just from the first initial treatment, and then administered topically on 1 to 2 hourly basis till for 10 days. After 10th day, if you feel that there is no epithelial defect, then you should taper the steroids, otherwise you can continue. And I am telling you that most of the general practitioners, they are scared of using steroids in these cases, but it should not be done. You should give steroids 1 hour leave-in and this most potent topical steroids. For severe inflammation, that is, if it is not controlled with topical intensive steroids, we can go for systemic steroids, and sometimes even systemic steroids, if it is contraindicated because of some sort of reasons, then we can go for immunosuppressants, or we can use this mycophenolate mofetil. There is no increased risk of corneal melting with concurrent use of ascorbate in severe chemical burns. So then third principle is this promoting ocular surface healing. Reepithelialization of the cornea is a key challenge in both acute and chronic management of the ocular burns, and topical ocular lubricants are essential for maintaining a moisturized ocular surface that facilitates reepithelialization of the cornea. Maintaining a moist ocular surface is also important to prevent the risk of further epithelial breakdown. So same way that promoting ocular surface, we can use this autologous serum, umbilical cord serum, or platelet-rich plasma can be used. And many studies showed that eyes receiving umbilical cord serum had a significantly lower mean time to complete reepithelialization, reduced limbal ischemia, and better corneal clarity than patients receiving only autologous serum or artificial tear drops. Then third principle is that promoting corneal stromal healing. So you know that inflammatory cells release matrix metalloproteinases, collagenase, and stromolysin, which leads to collagen breakdown. There is a strong evidence for the role of tetracyclines and citrate in suppressing the role of suppressing the release of proteolytic enzymes, and in scavenging free oxygen radicals that leads to this corneal perforation. So doxycycline is also good to inhibit MMP9 activity, and we prefer doxycycline 100 mg twice daily for at least 2 weeks. Significant reduction of ascorbate levels found in aqueous humor it is known to occur after chemical injuries. So inhibition of collagen synthesis that way happens, and this ascorbate and citrate act as the cofactor for collagen synthesis that needs for protection of the corneal ulceration and perforation. So combined ascorbate or citrate treatment appears to be more effective, and treatment should be done both topical as well as by systemic citrate and ascorbates. So when the corneal epithelium is absent, the eye is susceptible to infections. So in these cases, we should go for prophylactic topical antibiotics such as preservative-free 4th generation fluoroquinolones like moxifloxacin or datifloxacin, and also we can use these chloramphenicol drops. And when the defect is healed, then we should stop it. So acute chemical injury, there is a rise of intraocular pressure because of collagen deformation and shrinkage, distorts trabecular meshwork with blockade by inflammatory cells. There will be an immediate rise of intraocular pressure, so we should give this oral acetazolamides. And in these cases, to minimize toxicity to the epithelium, oral aqueous suppressants are preferred over the topical beta blockers, because that will further add this epithelial toxicity. To control pain, we should give these cycloplegic drugs or some sort of, that means painkiller tablets. And so to summarize the medical management, first we have to give topical corticosteroids, either dexamethasone or prednisolone, 1 to 2 hourly. Then topical antibiotics till defects heal. TR substitutes, that should be preservative free. And topical cycloplegics and beta blockers, topical ascorbate and citrate if it is available. And then oral doxycycline, acetazolamide, and ascorbate. Ascorbates should be given 500 milligram at 2 tablets BD dose, means 1 gram BD dose. So surgical therapy, that is this to promote reepithelialization, we have to go for amniotic membrane transplantation, we can go for large diameter bandage contact lens, we can go for congenital or tenon advancement, that is tenoplasty, limbal stem cell transplantation, and congenital transplantation. So in current scenario, the commonest indication of AMT is chemical and thermal injury. We recommend AMT in all the cases of grade 3 to 6 as per the classification of acute chemical injuries. If it is only 1 to 2, then that conventional medical management can help, but 3 to 6 we have to go for AMT. So AMT can be used both as a graft, which can provide as a basement membrane for epithelialization, and or as a patch where it acts as a biological bandage contact lens. AMT helps in ocular surface reconstruction, promotes rapid epithelial healing, and partially restores limbal stem cell function. So this sutureless amniotic membrane, that is Procara, can be used for children. Otherwise, we can go for freshly prepared or cryopreserved amniotic membrane. This is a video. This boy of 8 years came from Bihar to us after 3 days of injury. So you can see that this fornicial conjunctiva, everything was totally necrosed. So what we do? That this is near about grade 5 chemical injury. So you have to trim all those necrotic tissues and foreign particles are removed. So then we have to go for 360-degree congenital peritomy. Whenever we are doing peritomy, we should remember that that we should not damage that pre-existing limbal stem cells, which may be superficially injured, but deep-seated niches may be present there, and we should avoid it. and this limbal peritomy should be done at least 2 to 3 millimeter away from the limbus. We can fix it by using fibrin glue. If we don't have this fibrin glue, then we can use this tenonylon purse string sutures. As because here I'll be putting another piece of amniotic membrane, so I am just closing this peritomy sites by 260 vicryl sutures. Then we have to cover this fornix as well as the tarsal area by another piece of amniotic membrane. So in case if we don't have any fibrin glue, then here we have to just suture these things, this conjunctiva, this amniotic membrane, like in this patient, by tenonylon sutures, and then put 40 silk sutures over the bolsters in the fornix. So there should not be any raw area, and then I put this conformer, and then I put a suture tarsography. This conformer is removed after 2 to 3 weeks. Suture tarsography is just done just to avoid dislodgement of the amniotic membrane. This is the follow-up after 6 months. This patient didn't have any sort of symblepharon. Now patient is waiting for SLATE procedure. So in presence of scleral ischemia, that is a blanched out white appearing sclera. So in that case, amniotic membrane transplantation will not suffice, and this needs tenonplasty. And if I don't go for tenonplasty in these cases, scleral ischemia along with release of toxic substances can lead to profound inflammatory reaction, which may lead to corneoscleral melt. So what is tenonplasty? In 1989, Tapping and Ream first reported use of tenonplasty by stretching and advancing a viable and non-ischemic pedicle tenon graft from the adjacent fornix deep in the orbit, and that way it facilitates conjunctival healing. So it is considered as a globe-saving procedure that helps and accelerates the epithelialization of the cornea and conjunctiva through limbal perfusion. So this is a patient, 52-year-old man, molten metal injury 6 days ago. So you can see that this is scleral ischemia about more than 6 clock hours. So what I did this augmented tenonplasty. So the healthy conjunctiva is separated along the border of the male to ischemia by sharp waistcoat scissors, and radial relaxing incisions made towards the healthy fornix deep into the orbit. So all these are this ischemic scleral ischemia here. So we have to remove all those necrotic tissue and then separate this tenon's capsule from the overlying conjunctiva and underlying, if it is this extraocular muscles or anything like that, we have to separate it. And then we have to suture it over the ischemic part of the sclera. So this is in augmented tenonplasty, we can put a piece of amniotic membrane over the ischemic part, or we can put even a cyanoacrylate glue, and then suture the tenon's capsule over this amniotic membrane. Otherwise, classical tenonplasty, that there should not be any sort of glue or amniotic membrane over the ischemic part. So I covered this ischemic part by amniotic membrane, and then I sutured the tenons over the amniotic membrane by using 60 vicryl sutures. Then another piece of amniotic membrane is placed over this stenosis area. That is also fixated by using fibrin glue. And then, because it is two pieces, so I put one tenonylon circumferential suture to just fix both the amniotic membranes over the cornea. So this is the first amniotic membrane piece, and this is the second one. And then the cartilage of the conjunctiva is sutured with the amniotic membrane by using 6-vicryl. A bandage contact lens is placed now. So postoperatively, this patient also got the steroids, everything, and now this is the patient who, after 10 days I removed the BCL, and after 3 weeks I could see that there is a big corneal epithelial defect. At this stage I started using autologous serum 20% too early for this patient. So after 6 weeks this epithelial defect is smaller in size, and then after 3 months it is now almost healed. And after 6 months, it is perfectly healed. Now this patient is waiting for PK along with slate. So just to summarize, the algorithm for management is that acute chemical injury, first we have to go for irrigation, then assess the injuries, then prognosticate by Ruparhol or by Varsa Dua, topical steroids, promotion by, you should give it till 10 to 14 days. If it is not getting healed, then after 2 weeks you should step up for the steroids. Epithelialization can be done by either autologous serum or by tenonplasty. We can go for that is high to reduce the pressure. You can use this pressure lowering agents. We can use bandage contact lens, or we can use for amniotic membrane transplantation. Prevention of infection by topical antibiotics, and prevention of stromal breakdown by either frequent lubrications, doxycycline, and vitamin C. So after this close follow-up of these patients need, after initial injury, if possible, corneal ulceration and perforation, corneal scarring with LSCD, secondary open angle glaucoma, congenital scarring, symblepharon, all these things may happen, and that will be spoken by my next speakers. There will be dry eye, there will be exposure to the lid malposition. If it is there, we can go for tarsorrhaphy also. So to conclude, proper management in the acute stage is most important, and that determines the long-term outcome. When the globe integrity is saved and ocular surface is stable, one can plan further surgeries and for better visual rehabilitation, and based on severity and laterality, many options are there. So glaucoma, the most common comorbidity, and needs to be addressed aggressively. Thank you.